This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. A note about today's episode. There is some language that may be inappropriate for young listeners, so please consider this as you listen today. Thanks for tuning in. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is the way medicine is supposed to be practiced. I am Dr. Nitin Gupta of Rivertowns Pediatrics, and this is my DPC story.
Dr. Nitin Gupta, MD, F.A.A.P, is a board-certified general pediatrician who has a passion for delivering the best possible care for all children he cares for. After earning a bachelor's degree in Nutritional Sciences, Physiology and Metabolism from the University of California at Berkeley, he graduated from St. George's University School of Medicine and completed his residency in pediatrics at the University of Medicine and Dentistry of New Jersey Medical School. He also trained at Weill Cornell Medical College in Pediatric Gastroenterology and Nutrition. Dr. Gupta's adventurous career spans from working in the inner cities of New York and New Jersey to the far reaches of rural Maine. He has spent years working in the emergency department at the Brooklyn Hospital Center and urgent care at PM Pediatrics. He enjoys teaching and even filmed a pilot episode for a medical talk show. Originally from California, Dr. Gupta and his wife moved to Dobbs Ferry with their 2 young children, where they enjoy taking advantage of the great outdoors. In his free time, Dr. Gupta can be found hiking the trails of Westchester County, walking his dog through town, or paddleboarding on the Hudson River. Dr. Gupta is also an active member of Rivertowns Rotary, whose motto is service above self. Welcome to the podcast, Dr. Gupta.
Thank you for having me.
This is such a treat. Oh my goodness. So just for the audience to know, we've been texting this morning, a few hours before, but it's like I was up at 6 a.m. reading Carr's book with my Carr's.
Yeah, I was wondering why you were, because I'm on the East Coast and I got a text from you at 8 a.m. actually. And I was like, what is she doing? That
was when my 2-year-old woke up, and then an hour later was when he wanted to read about Radiator Springs. So I am ready. I'm so ready for an adult conversation. This is so good. So I got the pleasure of meeting you recently at the Pediatric DPC Mastermind, the very first one. And I'm so looking forward to another one. But, I think that it is so interesting. One of the things I found most interesting was that at that Pediatric DPC Mastermind, there was still, you can do peds in DPC? Like, that's amazing. And so you've been open years and years and years already. And, you're up there telling your story and looking around the audience, as is common at conferences about DPC. We still see people's chins on the table, like completely gaping mouths, like, this is real. This is not a magic unicorn piece of style of medicine. So with that thread that you are not a unicorn, you are a real person. Yes. Can you bring us back to what was your life like as you were choosing to become a pediatrician before Rivertowns Pediatrics opened?
Oh, okay. So the backstory, this the origin story, as many of us pediatricians, we're all fans of like comic books, or at least the people I surround myself with. Okay, so the backstory, what I come from an immigrant family from India. My dad was a generational engineer. So basically his dad was an engineer. All of his brothers were engineers, and dad before that were engineers. So naturally he came over to the US to, as an engineer in 1970. As you know, we talked, I was actually born and raised in the San Francisco Bay Area. My dad was an earthquake and structural engineer. So of course, California is, where we settled. When I was 6 years old, my dad had a heart attack. And so that kind of, I think right there was kind of my moment where I questioned my dad's mortality. Not question my dad's mortality. I realized my dad was mortal. And that's something 6-year-olds don't necessarily understand. So that was a tough experience for me, but that was probably that moment where I realized I'm going down the path of becoming a doctor, much to my father's dismay. So
You just ruined that generational line there, man.
I did. I was supposed to be an engineer. And my dad had a really good point. He was like, why would you want to be a doctor? You're going to spend all these years going to school, all these years going to medical school, then training, and then you're not going to start your life, according to him, that generation of Indians, you don't start your life until you get married, and have kids. So he was like, you're not going to be able to start your life or have kids until you're in your 30s. And well, I guess he was right. I guess like my first real paycheck really didn't come until like I was like 32, I think, as an attending. So yeah, there are many times where I thought, damn, why didn't I listen to him? But I knew I was going to be a doctor. I really got into nutrition because that was a major thing. My dad was a diabetic and he had a heart attack. He was only 35 when he had his heart attack. So nutrition was a major factor in his disease control, but also in our lifestyle at home. So that's knowing that we actually at that time, and I don't know if things have changed, but nutrition education in medical school was only, I think, 2 weeks long. That was the case for me in my medical school. So knowing that, I studied nutrition, physiology and metabolism at UC Berkeley. That was my undergrad. And then from there, and I was a pre-med right from the start, knowing I was going to go down that path. People always question me at that time saying like, how's nutrition going to help you as a doctor?
It's amazing. Like, really? It's just amazing now with what we know now, that's
now
crazy.
People are realizing. Yeah. I guess that maybe I guess that kind of tells you how old I am, I guess. But I mean, that was only like, 20 years ago, 30 years ago when I declared I was going to go into nutrition and apply that. But now, people understand. That's good. It wasn't until medical school that I realized I was going to go into pediatrics. And I've always been a kid at heart. And, my first rotation as a third year was internal medicine. And, I didn't like it. Not that I didn't like the medicine part. I didn't like the culture of internal medicine. There didn't seem to be the kind of care that I thought physicians should have. Now, I don't know if it was because physicians were burnt out already at that time, but amongst the nurses, the physicians, there was already a level of care that I just didn't think was right. And when I say care, I'm not talking about like putting in orders and, getting vitals and all that. I'm just talking about like human care, like and that's the thing. It was just like, I just didn't see that. And then my next rotation was surgery. And, Now listen, there are very fine internists out there and surgeons out there, but in that environment I was at, I mean, this was just a different beast of people. And maybe that was the medical culture at that time. I don't know. But my third rotation was pediatrics. And that's where I knew I was home. All of the attendings, the residents, the nurses, all the staff, they all did 110% of what they needed to do for those kids. And I think that definitely reflects in medicine in general. If you look at kind of the morbidities and mortality of diseases, our kids Sure, it's easy to say like kids don't get as sick. And sure, that can be, sure, I'll give you that. But let's also not forget that pediatricians also bust their butt off to make sure that that kid is not going to die, be harmed. We are the masters of preventative medicine. That's our domain here. So that's how I got into pediatrics. And I think even until my graduation day of medical school, my dad was like, there's still time.
It just makes me think of when I was talking with Dr. Katie Liu, how, she comes from an Asian background and I'm Filipino. And with you being Indian, it's just like, I feel this is very cultural. Like I can absolutely empathize with the subtle, passive aggressiveness of our parents sometimes. Oh my goodness.
Well, what's funny is like, there's like almost like, I guess with my dad's generation, a tribalism of like, we're the engineers. And you know what? The people who became doctors were the ones who couldn't do math. And so it was like a slap in the face. I brought shame to the whole family. But if you look on like every doctor in media, like TV, like there's at least 3 different Dr. Guptas on TV. So it's like, I was like, look, there must be other members of our family who went into medicine. And that's beside the point. So after I graduated from UC Berkeley, I was applying to medical schools. So at that time, I think it was like maybe, I don't know, super competitive. I think it may still be. I don't know if it's still the same, but it was super competitive. So of course I didn't get in. So I tried to, I was going to apply again the next year. I dabbled around in other things, other industries too. At one point I worked for a bank doing home loans. That was before the run up of 2008.
And proof that you have math skills. Great job there.
There we go. Exactly. Getting depressed and like, I'm like kind of, could I make a career working at that community bank? Actually, I probably could have, but I wasn't feeling it, So of course I'm getting depressed and wondering what are my options? What if I don't get into a medical school the next year? Because the application process takes like a year or two. It's horrendous. Then I've met some folks who went to St. George's University of Medical School in Grenada, and they were doing very well. And, they got residencies and they're great doctors. So I went. So that was it. An amazing experience. And I think having that experience really did plant that seed for this practice, Rivertowns Peds, because in that country, doctors made house calls. Doctors were available. There was no such thing as like health insurance, so if a patient couldn't afford the doctor's fees, the doctor just said, don't worry, just save your money for the medicine. And I'll just go charge the rich dude I'm going to go see next. That's literally what one of my attendings told me. That's how he made a living, and it was, if you think about it, that's a very socialized medicine type thing, but it was on the terms of the patients and the doctor. It wasn't dictated by somebody else. So just seeing that level of care and compassion that the doctors had in Grenada for those patients really planted that seed. And so
let me ask you there, though, when you talk about these home visits, how long were these home visits? Like, were the doctors pushed to see a certain number per day? Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
The doctor was his own boss. So it was basically it was the patient if they called the office and, he just went and made his rounds. And it wasn't, but for them, it was basically a fee for service. And so, if a patient called, then he went and saw them. If it was an elderly person, he went and saw them. If they could come to his office, he asked them to come to his office. And that's how it worked. It just worked for his village and his community. And seeing that firsthand and it wasn't just in Grenada. That kind of care is providing India too, in many countries across the globe.
Absolutely. My dad sat in the neurologist line, like outside of the neurologist's office.
Yeah.
And it was like, you will be seen after the person in front of you is finished seeing the doctor. There was no appointment time. So absolutely.
Yeah. But, the care was given. He wasn't rushed. And I saw that a couple of times. We also did a few rotations in the island of St. Vincent, same thing. And then we did our third and fourth year rotations in the US. So you go from witnessing doctors who are active leaders and compassion in their community to like Brooklyn. Not saying that there's no compassion in Brooklyn, but it's the reason why I got married in the middle of medical school to my wife. She was in finance. We didn't want to be in California because we just she's also an Indian American. Her family's from Southern California. My family's Northern California. Just watching, and I'm sure this expands all cultures, all immigrant cultures. The drama that happens after any person gets married. So we're just like, you know what? We're just going to move across the country. So that was it. That's how we ended up in New York. My wife basically moved her job over to New York City. And I was able to do the bulk of my rotations, actually all of my rotations in New York, in Brooklyn, New Jersey. And that's how we ended up. And of course, I applied for residencies. Tried to get back home to California. That didn't work. Matched at UMDNJ in Newark. An insanely incredible experience. I mean, it was just we saw. I think I was trained by some of the best diagnosticians in pediatrics, and the experiences. I don't know if anybody else can reproduce those experiences that I saw. It was definitely hard. It was a very hard residency, but I guess it toughened me up. Then I did a fellowship at Cornell in GI because I really, really wanted to apply my nutrition. As I thought proper nutrition will help prevent constipation, blah, blah, blah. So I did 2 years. I did 2 out of 3 years of pediatric GI fellowship. I absolutely hated it. Seriously, you cannot practice pediatric nutrition. There's no job opportunities for that. There was no hope in sight. It was either going to be, as a general pediatric gastroenterologist, it's like 95% of what you're going to see is reflux and constipation, and that's it.
Yep.
That was not for me. You really have to have a certain passion to manage constipation day in, day out. That I did not have that passion. Also, the thing was I moonlighted in the ER because I needed an asthmatic. I needed an ear infection.
Oh my gosh.
I needed diversity in what I saw. So I guess I just knew I was just a generalist. By the time my third year of residency was up, I was actually kind of sad I was going into the fellowship. But, I basically applied for that fellowship my first year of residency.
I can believe that easily. I mean, just peds fellowships in general, they are very, very hard to get into. I mean, I think about my roommate in college. She is one of the best surgeons and one of the best people I've ever known, roommate in medical school. And she is still applying for ped surg fellowship because the demands that are on the fellows and then the research that is needed to be able to be accepted into the fellowship that she's going for, it's quite challenging. And so
that's interesting. She's going for a ped surg fellow. The sad thing is the fact that she's going to go do a pediatric fellowship. She's going to take a massive pay cut in her compensation potential.
Oh, for sure. And I mean, we think about the people who didn't go to med school, who after undergraduate went to Genentech. In my case, like a ton of people went to Genentech, and it was like they have
Oh my
mortgages
God.
and homes and 401ks. And we're like,
Yeah.
we're paying a medical school to go get education to take care of other people. And it's a lot of money when you think about it at the end of 4 years of training. And then you make, you work 80 hours a week and you make $52,000 a year. So it is a definitely dedication for, and it's not for everyone.
Yeah.
Let me ask you though, when
Yeah.
you said that you completed 2 out of your 3 years of
Yeah.
fellowship and then left, it makes me think of, Dr. Janet Naribas, who's near you.
Yeah.
She moved off of Broadway, but she was a surgeon before she left to go to family medicine. What was your experience like, internally when you were like, I literally am a 2 out of 3 year fellow. Like, how can I leave? Because I think about people
Yeah.
staying
So,
because
yeah.
of, shame or guilt or whatever. So what was going on in your head?
So what was going on in my head was during the whole time in fellowship and even towards the end of my residency, my dad was dying. So, these are the repercussions from having a heart attack at 35, and diabetes for 3 decades. And so he was having multiple TIAs and got to the point where he wasn't able to walk. He had massive, terrible dementia. And so I basically left home at 18, right? Then whatever it took to get to medical school, then residency. There's basically a void in everything. I missed that much my dad's life. And then I find out my dad is dying and has only a few years to live, or a few months by the time. So I was trying to go every weekend, flying back to California to go see him, help out my mom. I was getting hospitalized left and right. I was miserable in my GI fellowship because, look, I shouldn't have been there. I really should have been, I was very satisfied. I loved general pediatrics. From day one, I realized, crap, I am not into constipation as much as I'm trying to will myself into. And so in my second year that my dad's like, why are you there? Like, you're not happy. And this was during his lucid moments. And he's like, that's just extra credit. You already did your residency. Like, why aren't you practicing? And it kind of got to me and I kept remembering that. And then finally, after running out of PTO hours, whatever, no more vacation days, no more sick days, because I kept flying back and forth. I said, forget it. I'm just quitting. Like, there's just no point. Like, I probably wasn't even going to be like, would I have even practiced if I finished? Like, there was just, why not? Let me just quit. I spent basically what would have been my, 6 months, the next 6 months by my dad's side, and he passed away. And I have zero regrets. Then it took the next couple of months to help take care of my mom, get the family's finances in order. And from there, because I did hate kind of every day working in my fellowship, I did see a lot of the ugliness of medicine in New York City. I didn't even know if I was going to did I even want to go back to medicine? There at that time, there was a lot of hedge fund opportunities to go work for. There's a lot of questions in my mind if I even wanted to continue. Just because seeing how also the way my dad died, how my dad was dying, it was just, you see the ugliness of kind of end of life care, the limitations of kind of, chronic illnesses, how the medical system kind of helps those people or doesn't help.
Absolutely.
And so I was disgusted by medicine in general. But the funny thing is, while I was at home, kind of with my dad in his last days and with my mom, there was this like locums company that had talked to me. And there was this hospital up in northern Maine, in Caribou, Maine, where the CEO, they were clearly desperate. They needed help. And this my locums agent, I was like, yeah, fine. He just called me out of the blue. I was like, okay, cool. I'll entertain. He's like, yeah, we can get you, a position. You could work temporary all over the country. I was like, sure. I was like, that sounds good. Sent him all my stuff. And then he's like, hey, Dr. Gupta, I got a great opportunity up in Caribou, Maine. I was like, Maine? That sounds cool. That's where Stephen King's from. But I wasn't serious about it. I was like, let me just explore the idea. And I had a telephone interview with the CEO. And this was like in August of 2011. And I just kind of kept in touch with them. I said, I'm not ready yet. My dad is sick. I'm not ready. And it was after my dad died. My dad died in October 3rd in 2011. The CEO called me October 4th. He's like, I just wanted to check in. I want to see how your dad's doing. And I was like, well, he died. I'm like, oh, I'm so sorry. And he was just very compassionate, sent flowers. And I was like, right there, I was like, you know what? I'm going to Northern Maine. That's how it happened.
Oh, man.
Yeah. January 3rd to March 3rd, I was up in Caribou, Maine. That was like the dead of winter up there. I had never been so cold ever in my life.
It's just crazy because I think about you growing up in California and then going down to like Grenada and St. Vincent and then going to Caribou, Maine. Like you've pushed the limits with regards to, what you can, temperature and practicing in all those situations, because the patients are totally different in those situations too. Like,
so the patients,
I remember
I'm a student of culture. I do like to explore. I like to see the different cultures. I think one thing, the reason why I struggled training in New York and the New York metropolitan area was there was a lack of compassion. Now, people are going to deny it and be like, no, we're very passionate. No, we aren't. We're New Yorkers. And in training programs are malignant. That's what residencies and fellowships are. They're malignant. And, they really should be HR nightmares. And I'm surprised there aren't more lawsuits amongst these things. But doing all my training in the New York metropolitan area, I didn't see the compassion that I saw in the Caribbean. And I thought, this is how medicine is. Like, New York is supposed to be the Mecca of everything. And it's like, oh, well, this is how medicine is. So anyways, I went up there to Caribou, Maine, and it reminded me the compassion was there. That was the thing. The neighbors, I had this, at that time, she was a 70-year-old nurse named Sandy, and she just knew the history of everybody. She knew, a busy day was 12 patients a day over there. And Sandy would give me like a 30-minute briefing on every patient that was coming ahead of time and to tell me the whole history. And, everybody knew each other there. There were stories of like one neighbor going into labor and there's a massive blizzard. So somebody from the hospital went in a snow sled, picked her up, brought her in. Same thing. Another snow sled went and got the OBGYN, brought them in. These were just things that and this wasn't like they weren't paid to do this. They were just their passion. This is their community, their neighbors, their family. The briefing that Sandy would give me every time I saw before every patient, there were subtle things like, hey, this family, they have dirt floors. I was like, really? Dirt floors in this winter? She's like, yeah, they're basically, she's like, yeah, they're poor. And I said, oh, how did they get here? Because they came from another, like a village, like 30 minutes away. Oh, they borrowed a friend's car and the neighbor brought them over. But what that told me was like, well, that visit that I was going to see, that was the visit. They pulled so many strings and did so much to get to that appointment. So that meant I wasn't going to talk about one single ICD-10 code or ICD-9 at that time code. I think that coding is one of those kind of led to our decrease in compassion, where we have to, every patient has to be classified as a single ICD-10 code. But I had to address everything. That's what that told me. And I didn't care and basically it didn't matter if we were getting paid for multiple ICD-10 codes. We had to address everything and go into the sample closet, fill out that supplies, give it to that kid. But that renewed my passion for medicine, for pediatrics.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well-child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. That's awesome. And when you were in Maine just for a locums and you said you left in March, what was, with this renewal of your passion in general peds, what drove you to find other jobs after that before Rivertowns?
It was terrible. my wife, she wasn't going to move. Right. So her career is taken off. So I basically just kind of bounced from job to job. And again, it's a difference in culture and of the medical culture, of the patient culture. Let's also say patient culture too. So I right after Maine, I took a gen peds job, outpatient gen peds job in Astoria. And that area, that neighborhood was, there was a lot of anti-vaxxers. There was a lot of vaccine space, air quotes, I'm saying vaccine spacers. They're the gentle anti-vaxxers. I guess they're the ones who are like, no, we believe in vaccines, just not right now. I was like, so when? Well, never, but we believe in them. I was like, okay. I couldn't deal with that. And so the doctor I worked for, he was amazing, very passionate. He started the practice 40 years prior, but cultures changed. Ideology changed. And so he was kind of getting pushed around by the patients. I lasted 3 months in that job. I say, you know what? Screw that. Nobody cares about preventative medicine. Then you know what? I'm going to go back to the ER. And so I started working in ER again because I felt like there was no credit for being the general pediatrician, being preventative. Let's go to the ER. Those guys get the credit. So I worked for 5 years at one of the hospitals that I did my rotations in. An amazing experience there. But, towards the last 2 years of that experience, you really saw administrations kind of move in, take a heavier hand in how things were run. They stripped our ER of our nurse. They limited our access to the medications. And it was kind of well, what the hell? How are we supposed to attend an emergency if you're taking our tools away, our support away?
The Pixel's not working. That was my favorite in the ER. The Pixel's not working. Yeah. I can't. Yeah. Pyxis.
Just overhead page the pharmacist. I was like, really? The one pharmacist for the whole hospital? He wants to overhead page and he's going to drop everything and come running down. But this was the cost cutting. It's lean operations, right? This is. I'm all for capitalism. Cool. But not in a hospital setting. It's okay to have some redundancy. It's okay to have some glut in certain areas because you have to be prepared for those emergencies that are going to come. So it was getting harder and harder. And, I think what kind of set that off was there was a hospital kind of a few miles away that basically got sold to private equity, and it got turned into luxury condos. So the land that hospital was sitting on was worth more than the hospital itself. And guess what? The hospital I was working at, guess what? It was pretty obvious. The writing was on the wall. Now that hospital is still standing, but only parts of it are still there. But I think what happened was, I think COVID changed the game a little bit. There was going to be less kind of that hospital was on the chopping block, but COVID kind of kept it going barely. But anyways, I lasted there for 5 years. I found my forever home up in Westchester anyways, after that, which is about anywhere from an hour and a half to 2 hour drive to work.
And with traffic, I'm assuming?
Oh, with traffic, 3 hours.
Oh my gosh. That's insane. I'm very New York naive because I've only been to Binghamton to see the carousel and then nowhere else in New York to this day. So I appreciate LA traffic. So I can sort of picture the parking lot.
You came to my great state of New York and you went to Binghamton of all places. That's the only place you went to, Binghamton.
So I was 12 at the time.
Okay.
I'm 40 now, but I will tell you that my uncle refurbished a 1938 Studebaker and was in the Great Race, the North American, or I think it's the North American Great Race or the Great Race. So
Uh-huh.
it was a timed race between Ottawa down to Mexico City. And so Binghamton was one of the stops. That's the only reason I have been to New York. So
Wait, he raced in a refurbished Studebaker?
yeah, so he
Okay, well that's a completely different podcast. And
yeah.
that is an interview. That is a story that needs to be told.
It's great sharing the back seat of a van with your cousin who takes the seat laying down, and I was sitting down the entire trip down to Texas. So yeah, it's good times. But
Yeah.
I think about this, you're coming from what I keep hearing is the word compassion, and that is awesome. And I think about going back to the PEDS DPC mastermind, how, a big discussion was about equity and, in the AAP world, equity and pediatrics, are supposed to go together. But I thought about when you were sharing your story, how the time with patients that matters, and the compassion that you have with patients that matters, not just equity, because equity is great. But then what happens if everyone has care, but the care is 2 minutes, 8 minutes, 15 minutes? Like what is that?
I'm glad we're talking about that, because this is a big equity. Sounds fantastic. It really does. But again, it's not realistic, and actually it probably harms. And let's talk about that, because equity sounds great on paper. However, you got a kid with multiple medical complications, a very sick kid. We currently have a few kids who are very complex. They have complex care. A lot of complex care coordination that needs to be done. They're paralyzed from this kid's paralyzed from waist down, like lots of, you know what, honestly, that kid does not need equal care to my son who's 7, who barely gets sick. I don't want that. I want less care for my kid, and I want to dedicate more care to this kid. So we have to talk about that. That kid needs more compassion. My son needs compassion. That's fine. I'm good. But that kid needs more care. And we shouldn't be afraid to say that.
Totally. I absolutely second that. My cousin, who in my mind, he's always 4, but he's now, I think, 24. He has Down syndrome. And so he had occupational therapy, music therapy, physical therapy. What else am I leaving out there? Speech therapy. And it was because of all of that intervention at such a young age that he's a flippin' DJ. Like, he's a kid with Down syndrome who does DJ. Well, excuse me, an adult now, but I absolutely agree. Like, personalized care is what's needed. And that personalized care is not going to be like, you can't have the black and white one paper, fill this out. That's your visit. That's not going to allow a child to get the care that they need, for sure.
Yeah. So it's the compassion, community. Also, needing, for instance, our kid who has our most complex kid right now, the community has actually come together. There's a community organization that is actually paying for his membership with us. And that is key in this kid's care. We confuse healthcare with health insurance. We confuse health insurance with equity. We're basically putting more importance on payment than we are on care and compassion and community. And this is what is failing our kids. So when I first started off on this DPC journey, there was only a handful of us. This was about 5 years ago when I went on this journey. And I think from those who were doing this, they were adult docs, they're family medicine docs. All I heard was like, I don't think you'll succeed. And I was like, why? And they're like, well, kids all have insurance. I was like, but the kids don't have care. They may have somebody footing the bill, but that doesn't mean they have care. And so what I mentioned in my talk at the mastermind was what I discovered was what patients lack in this country, which actually most patients lack, is the access, the quality, and the convenience, the AQC.
It's so true. And, I had been talking with Dr. Shannon Scholl, who's a adult gastroenterologist, and we were talking about, being a disruptor. And then I was reading, I think it was the Harvard Business Review magazine, and they were literally defining disruptor as bringing more innovative solutions, specifically cheaper, simpler, and more accessible.
Yeah.
And I was like, there you go. There you
Yeah.
go. That's how innovation
Yeah.
has, I wanted to ask you this because like when we think about innovation and, just pulling from the fact that your wife is in a different profession and is on Wall Street, I wonder when you were in those early days, because there weren't a lot of mentors, and that's really like super irritating to me to hear, like, the poo-pooing of like, I know you have a dream. That's cool. Oh, you're so good. Like, oh, bless your heart, but that ain't gonna work.
Yeah,
And,
it was like,
and now, yeah. And now, you've blown that fallacy out of the water. But when it came to, I've done the 5 years in, stint now in ER. I've done all the things. What I want to do is general peds. And when you were dreaming about Rivertowns, coming from your wife's perspective of, appreciating innovative changes in the markets and, investing in things that are disruptive, in that definition that I mentioned earlier, that can really change culture and change finances and change everything. I mean, now we're seeing DPC as a model that can be really taken forward to the next level by incorporating it in, with employers, with state employee plans, with school districts, all of these things. But what was the discussion like when you were dreaming about Rivertowns with your wife because of her different perspective?
So my wife, she took a finance angle to it, where she's an analyst. So she dissects like the companies that she covers, and she can tell you where they're losing money, where, what's making more money, and what they should be focusing on. With me, it's always been gradual conversation. It's always been constant conversations for over a decade with her about like my thoughts of how medicine's run. I always chat with her. And so she always kind of kept that in mind. She realized when I was going to be like, I'm not going to take insurance because you know what? It's insurance that's fucking this up. But by the time I started this, when I left my job 5 years ago, it was hard to find an independent practice anymore. In New York, all the independent practices are being bought out, air quotes on bought out. They're not getting bought out. They're being incorporated. They're being absorbed. Basically, the big hospital groups are saying, we'll pay your overhead. There's rarely a big cash transaction. The reason why you want to join us is because we have the big insurance contracts that we made sure that they squeezed you on.
And as we're talking, that there's the one company out there, and people can go find this. The one company who, oh, you're struggling with your clinic. We'll do all of the work for you. We're going to take I think it's like 0.5% of all of the payments that you do get, because we're going to do all of the paperwork and all the insurance, forms for you. Oh, you're still struggling. Well, then how about you take out a loan? But you can only get the loan if you use our, paperwork processing service. And then, if you're still failing, we'll just buy your clinic. And it happens to be, this is an insurance company. Like, patients do not have an idea. And at the same time, I was reading about this. I had a patient literally drive up to I love your Maine story. Like, I love that the neighbor drove that family to your clinic, but like legit people will, because my clinic's across from the post office. It's like, whoa, they will U-turn into my parking lot, honk the horn and be like, no care for anybody else in the neighborhood. But hey, you know what? I got my 90-day refill for $1.42 because I used that magic insurance company. And so, it is definitely like education of our culture is a huge thing. And so I love that you're sharing this story and telling it like it is from your history, because people don't get it that, like you've said, insurance is not healthcare.
Yeah. Insurance is not healthcare. So, I broke it down. I was telling my wife, like, look, if I've reached out to a couple of independent pediatricians. They told me like their reimbursement for like an ear infection is like $992.13. They're getting $32 for that. $32. Think about that. Now you're in New York, and I'll tell you my estimate at that time was, if you're an insurance-based practice, At that time, your operating costs were about $300 an hour per doctor. So that included, your overhead. Your overhead included your MAs, your billers, your everything, all that glut. So imagine if you're getting reimbursed $32 for an ear infection, how many patients you got to see, right? So, but on the flip side, we got so addicted to insurance. That was the only thing we knew. But, you think about it insurance, in theory, the insurance is supposed to make it a healthcare affordable. How is that affordable when we're charging like $200, $100 for a flu A test, $100 for a flu B test? That's $200 right there. If somebody else is paying the bill, supposed to be paying the bill, what do? You upcharge everything. And so that's only driving up the costs. We keep driving up the costs. That $40 rapid strep test that a clinic will charge. Well, that strep test is $2, $20 for that UA. The UA is 80 cents.
Yeah.
So what if you just, instead of the thing, what everybody's paying is thousands of dollars a year in insurance. They're paying thousands of dollars a year in their deductibles. They're paying their co-pays. Well, what if you just paid the doctor directly? Get better care, get more convenience, get quality, get the access, and you pay the doctor directly. It doesn't have to be expensive. Just cut out the administrators, cut out the overhead, cut out the insurance, cut out the hospital facility fees, cut all that out, and actually just put care back between the patient and the doctor. That's it. It's really easy.
What blows my mind to this day, and will probably for the rest of my life, is that we will talk to people who are old enough to remember that that's how medicine used to be, period. I think it was Jimmy Carter was the first president born in a hospital, legit. Yeah. I mean, there's people who...
It was only 30, 40 years ago.
Yeah.
It was that managed care. It was 35 years ago that managed care became the status quo.
Mm-hmm. Yeah. And
that was it.
It is so sad when you talk with doctors who were at that cusp of HMOs and managed care. It was like what the internet promised, this utopia that has not happened. Yeah. But it's like when we think about managed care and the promise that people really believed in, it was coming from, wow, this can make healthcare more affordable for people. That idea that people bought into. It's so sad because it was such an earnest desire, and then look what it's turned into. But it is so interesting how we've gone in such a short time, relatively. How long was the Roman Empire in power, and then how long has the United States been in existence, and then look at our healthcare system. Just within a short time, we've really gone to this place of I'll only do what my insurance covers, not thinking about what does that service actually cost, or what does it mean to me? Oh yeah, I forgot the fact that not only am I paying $40 for that strep test, but then I'm also paying the bill for the urgent care because I couldn't get in to my doctor to get the strep test.
Yeah. There's another thing. So I had this long conversation, not a conversation, a debate with a medical student. He was like, well, how are you helping people? I believe in healthcare for all. And I was like, I do too. He's like, but then why aren't you taking insurance? I was like, oh, no, I don't believe in health insurance for all. He's like, they're the same thing. I said, no, they're fucking not. I wanted to go to the dean of the medical school and say, you need to educate these people.
For sure. It's just like nutrition.
Telling them that health insurance is healthcare, you're screwing them.
Well, it's just like nutrition, like how you were saying, your education nutrition. And I will second that. I had zero courses in nutrition that I recall at Creighton. And when it comes to the things that we need to be educated with, I was very jealous of my dental friends who would be like, oh yeah, I know about, ideal patient. I know about P&L. And I was like, where did you learn this stuff? We just learned about the heart today. That's you guys are going way beyond. And
well, so now what's important though, is I have no sympathy for physicians who say I didn't learn anything about business in medical school. It's since when the hell did you stop learning? You're the smartest kid in your class, in high school. Why did you stop? So go learn it. But also the thing is the business of what my practice does. It's really simple. There's nothing complicated about it. I know what my overhead costs are. They're a hell of a lot lower than they are if I were to take insurance. And this is how many patients I need at my rates. And this is how I can turn a profit. It's really, I'm not worrying. I'm not pinching pennies, waiting for a reimbursement from an insurance company. Like I'm not going to hold my breath for 6 months waiting for a reimbursement, only be told like, oh, we decided that was too much. We're going to pay you this much. No, I know exactly what my monthly income is every month. And I know how to hire accordingly. I know how to make my expenses accordingly. And that's it. It's really simple.
When going back to your wife and the discussions, I love that you had the discussions over 10 years. It's amazing. Like, I love the long term.
So, basically, if you try to go get a small business loan and say, I'm not going to take insurance, you're not getting a small business loan. So my wife was my loan. So basically, all I had to do was, I didn't even write anything on paper. I didn't even have to present anything. I was like, Priya, here's my idea. My rent is going to cost me $3,300 a month, and I'm not going to take insurance, but I'm going to, and my malpractice at that time was like $9,000. It was like, if I were to have 400 patients at $100 a month, I'd be rich. And she's like, $480,000 a year. Your expenses are this much. She's like, yeah, that would work. That was our discussion. She's like, well, what about the testing? I was like, look, a UA is 80 cents. A strep test is $2. A flu test is $10. I was like, I just absorb it into the cost. That's just part of my monthly cost. She's like, what about the vaccines? I was like, that's going to be a little scary. So in the beginning, I said, here's what we're going to do. I'm going to just market to like toddlers and up because they don't need as many vaccines. And then I'll figure out the vaccines later. And that was my business plan with her. And it worked. Of course, now I don't have 400 patients and no, they're not paying $100 a month. Things have changed. Times have changed. I just, you can't, again, let's go back to equity. You know what? Those newborns are not the same price as a 14-year-old. So the newborns pay more, the 14-year-olds pay less. But on average, at this point where I am, because there is inflation, rent does go up, malpractice does go up. There was a couple of there was a pandemic and some, like shipping delay. So costs of goods have gone up. So on average, our patients on average pay $125 a month.
I'm going to be the devil's advocate here, but I thought that you could only charge $10 a month for a kid. So tell me about that. This is an ongoing discussion and debate. I'm totally being devil's advocate in here, but to those people who say it's $10 a month, it's $25 a month, whatever. How does your mind process that argument of the flat rate for kids, period?
Honestly, would you trust a doctor that only charged you $10 a month? How good is that doctor? What kind of care is that doctor going to give? Let's just leave it right there on that. Think about it. I mean, that's ridiculous. It's just ridiculous. Those same people who are charging too little are also the same people who are complaining that they're being overutilized. Well, it's like, because you're being overutilized because you're charging like $10 a month. Your patient population, the community, they need to also know that you can pay rent and eat. So if you're charging $10 a month, guess what? You're not getting pediatric patients. You're not. There is a thing when you have kids, how many kids you got?
2 boys.
Do you ever go on Facebook to get the Facebook parent groups and ask hey, can somebody recommend just a so-so, it's just something that's so-so. I just only want to pay $10. No, people they go onto the Facebook parent groups. They always ask for the best, best place to get a haircut, best place to send my kid for daycare, best place. They don't ask for $10 a month. And now I'm not, that sounds, I'm just being realistic on that. You're just not running a practice with those. You have to be realistic.
I'm glad you're talking so transparently because it's important for other pediatricians to hear that, especially if they're considering direct primary care.
Yeah, but
as
I
a
don't
business
understand
model.
are those pediatricians who are getting their advice from non-pediatricians on how to start up their practice. Like, why would you do that?
That is where it's so important that we see a PEDS DPC mastermind. We see,
Yeah.
pediatric groups, because absolutely, like, DPC is a business model. Okay, we can learn from each other general things. But when it comes to pediatricians as specialists, you mentioned in a previous interview that, like, what is the drive to go into pediatrics in your case, but primary care in general, internal medicine, general internal medicine, general family medicine, pediatrics, when look at, what we do in fee for service, the typical thing that a medical student will see or a resident who's rotating will see is what I heard another resident call a primary care doctor a referralologist. And so it was mind blowing, to hear that from a first year resident who's in family medicine in California. But then hearing you talk about, like, what is the drive for people to choose pediatrics in general? Like, if we're devalued by the fee for service system because
Devalued by
$32,
the American education system, the medical education system, we're devalued by the medical system, and but that's an intentional devaluation. Look, I mean, CVS and Aetna are now a company. What is it? Optum, which is UHC, they're gobbling up hospital groups. Cigna is gobbling up hospital groups. You're an idiot if you don't see that the insurance companies are taking over, right? And to them, if you're an insurance, here's how simple it is. Insurance companies make money by not paying the money you give them. That's how they make money. That's what insurance is. You're paying a company to hold on to your money. What they're going to do with that money is they're going to try to grow that with investments or whatever. Some would call it a Ponzi scheme. It kind of is if you think about it. But they hold, because that money on hand for them is valuable. They can invest that. They can grow that money. That is their goal. Now, in order to continue to grow that money, they can't dispense that money. So they're going to do everything possible to not pay. So if they're buying out hospital groups, they're buying out practices, then, you're going to be irrelevant. Generalists, primary care. Now, in medical school, the amazing thing about going to medical school in a different country is the smartest people go into primary care outside of America because they're the ones who have to know everything. And so if you go into a specialty, you dumb yourself down into knowing everything about that one thing. My research project in Peds GI, guess what? I was going to be the world's foremost expert in pediatric gallbladder disease. Guess what? I would go bankrupt. I knew everything about the gallbladder, like the pediatric gallbladder. There is no job prospects for that. But I would know a whole lot about very little. And I'm a geek. I love knowledge. I love it. So that's why I love being a journalist. I love being a jack of all trades. I just the other day, I went and stitched up a kid because I still keep those skills. I love being that person. I'm not a referrologist.
It was patients, we don't even, that's not, not a real word. I'm sure Urban Dictionary might add that someday, but it's we all know what that means, right? So continue.
We all know that. My patients pay me directly to be the best damn doctor for their kid. I work for my patients. So if I were to work for an insurance company, of course I'd be referring like crazy. When I used to work for a hospital system, the mantra was, if it takes longer than 7 minutes, refer, but only refer to one of our specialists because that counts part of your RVU. So, how does that not violate Stark laws? I do not know. But again, I don't give a shit about that. I just care about me running my business and doing it well, and I'm doing it well.
It's awesome.
I have a tiny little practice, and we're one of the largest. We are the largest pediatric COVID vaccine provider in the county. My little teeny tiny practice.
It's incredible. And, I wouldn't even say that it's teeny tiny because look what Rivertowns has, developed into. I mean, just in your clinic, you have.
We just hired a new pediatrician,
yep.
Dr. Mindy Gallagher.
Yep. You have Dr. Gallagher, you have Dr. Solomon, who's family practice. I mean, you clearly that poo-pooing of that's such a sweet idea, but that's not going to work. Has
well, we also
away.
have Staten Island. We have
Yes,
Rivertown,
yes.
Staten Island,
Yep.
Dr. Vladimir Beriev.
Yep.
So he was my grasshopper. He was
Love it.
he was my Padawan for a while, and then he opened up over there. It's something. It's not a concept that was going to be like a good luck to you. I wish you the best. It's what's absolutely necessary because this healthcare system is failing.
When we talk about your growth, I want to take a step back into the first days of Rivertowns, because before you added on physicians at Dobbs Ferry, before Staten Island opened up, when you were going from talking with your wife, getting, she was your small bank loan or, small business loan, and then opening, how did you then use those finances to fund your DPC and bring patients in?
Okay. So I think in the DPC world, we like to talk about how you can open up your practice on a shoestring budget. Cool. Yes, that can happen. And that's good. That's fine. But I'm going to be realistic. Look at the market you're in. I'm in New York. I'm in New York City. I am, there is nothing shoestring budget here. I am surrounded by hospital groups that have Super Bowl commercials. I don't have a Super Bowl commercial. And what boggles me is that they have Super Bowl commercials that they say they're the best. I don't know how you have 5 hospitals saying there can only be one, but whatever. I digress. For me, did some market research, polling people around. I needed an office. That's my showroom. I needed a home base. By having an office, by having a 5-year lease that it says I'm here, I am serious, I am going to be your pediatrician. Yes, I do house calls because why? Because nobody else does house calls. I marketed the hell out of that. The budgeting. Before opening up, I paid off my student loans the year before. Doing locums was a big help. Living, my wife and I, we try not to splurge too much early on. Now we do splurges, but we did everything we could just pay off our student loans. At those times when I was doing like home loans, like for that local bank, I learned a lot about loans. So that really got me in my mindset. Let me dedicate to paying off my student loans. So pay off your student loans. If you're going to go down this path, pay off your student loans. You don't need that on your mind. Save up a nest egg. Save up a nest egg that can support you for about the next 2 or 3 years, because it might take that long for your practice to take off. And what Dr. Vladimir Beriev said at the DPC Mastermind is in 5 years, half the people, or what do you say, more majority, or was it half? Majority of people were going to fail.
I think it was majority. Yeah.
Majority of people were going to fail at 5 years. So you got to have that nest egg. You got to be prepared. And so when I first started the practice, so I started with a $100,000 budget. I'm in a big market with big names, with lots of flash. So $50,000 of my budget went to marketing. In my area, social media is the biggest form of marketing, or is the most efficient form of marketing. Everybody, parent group, there are Facebook parent groups. That's a big market for me. Now, look, I'm not targeting senior citizens who look at print ads. No, my demographic, average parent demographic, average age is 35 for parents. So they're on social media. They're on Instagram, Facebook, also Google. So we have a big Google presence, Facebook, Instagram. I no longer pay for Google ads because I don't need to. Yay. But, marketing materials, the business cards do make a difference. I know it sounds old school, but you just drop a business card, drop a stack of them, drop brochures. That's what I did. Just went around everywhere. Pre-pandemic, of course. During the pandemic, we doubled down on the social media marketing even harder. And you also got to remember, if there is something that's working in terms of marketing, push that farther. You don't be like, hey, this post really worked, or the message of this post really worked, and then change the message. No. Keep messaging. That's your ticket right there. And then adjust as the times change. Right now, if you were following my social media, we've been targeting a lot of newborn house calls because we have a little baby boom going on right now. So guess what? I want all those newborns. So we've been doing a lot of newborn house call posts. You got to know your market in the beginning. Throughout, not just in the beginning. You got to know what your market needs. My market needed COVID testing. My market needed COVID vaccines. The big hospital systems couldn't get their act together. They couldn't do the testing. They couldn't do the vaccines, but I did. And so we did it. That's if you're going to charge people out of pocket more than $10 a month, you got to give them something. You can't just be like, and you got to make sure, you're doing it for the right reasons. Are you doing it because you need to be the doctor that you were meant to be? Then yes, go for it. If you try to go down this path because you just want a better lifestyle and make it all about you, well, you're going to fail. People read through that. So you got to make sure you're better than everybody else.
When you talk about marketing and, strategizing specifically for your market, given that you're amongst these hospitals that have Super Bowl commercials, I love that so much. How did you go about developing a marketing plan to be so effective?
So I teamed up. I interviewed a lot of different local marketing companies, and I didn't settle on. I one day interviewed Lauren Dawn and told her and her team what I was going to do and what I was hoping. This is my plan. I'm not going to take insurance. And she said, you're going to start a new industry. And I was like, you know what? Let me cancel all my further interviews. You're the one. And that was it. She got me, because this is what we're doing. We're not starting an industry. We're resurrecting a former industry, but we're bringing it back into focus. And so that's what we did. Except what we did early on, we realized I tried to do so I was too hands-on in the beginning. Lauren would always tell me no, we shouldn't do it that way. So again, she's the specialist at what she does. So for the first 3 months, she's like, we should do it like this. And I was like, no, but the DPC handbook says I should do it like this. So I talked about how you don't need insurance. And these are the benefits of me versus an insurance-based practice. And I talked about all the different types of finance and money and how you're going to save money. And Lauren's like, okay, I'll give you 3 months. And guess what? We went nowhere. And then after 3 months, I'm like, oh my God, Lauren. She's like, okay, so can I work now? And I was like, yeah. So we took down our rates on our website, because she has these little widgets on the website that show you how much time people spend on what part of the page. People clicked out right there on the pricing page. She took that down. And then she made it all about me and what I offer, my expertise, and then made it about the patient, what you need, made it about your kids, about the kids. That's what it was. And it was basically the marketing went back to the patient and the doctor. That's what it is. That's what parents want. And the difference between the marketing between the Super Bowl commercial hospitals is they always say only at New York Presbyterian, only at Montefiore, only at Northwell, but they never specified as the doctors. And there's a reason for that. Why? Because doctors leave, because they're just a number. For us, it's the marketing is about when we market it, we specifically say Dr. Gupta, Dr. Gallagher, and we keep it about you as well. So the messaging, it's important. You have to introduce people to who you are and the relationship.
So let me ask you there, because, locally it is extremely hard to see anybody of physician or non-physician provider who sees kids in our area. And so really common in our area is, I'm going to go and get Blueberry Pediatrics. That's the local, the local draw. So when you talk about
that's the telehealth.
Yeah. And it's so interesting because, the commercials that I see, Facebook, Instagram, it's definitely heavy social media. But as you talk about you guys marketing yourselves versus how these hospitals are marketing the system, I see Blueberry Pediatrics is the example here where it's Blueberry Pediatrics, the name of the company versus the doctors. Are you finding, because you guys are growing, adding physicians, there's a need that keeps being met by your clinic? Why do you think people are preferring you guys as you're marketing yourselves versus something where it's marketing a company, but it's still accessible, affordable virtual care?
Parents want a doctor. That's it. They want a doctor to see their kid. They don't want a device. They don't want a hospital system. They don't want a clinic. They want a doctor that they can trust. Blueberry Pediatrics, they're fitting a role. right? So a lot of what we do is a lot of what they do. I feel like I want to say we've been doing it first, but I never really investigated how long, because we send a lot of our families the Bluetooth otoscopes, and we do a lot of video health, televideo. We do a lot of pictures. We do a lot of video, but those are fine. Like we got a fungal diaper rash. Yeah, we can just get a picture on that, or but I can't take a strep test through a video. If you got a Bluetooth otoscope, it's like some of our families are very savvy with it and they could do it, but the majority can't. So also, there's also, I think that we're not going to go down that. We're just not. We're not going to do. There are some devices that can record the heart sounds, lung sounds. We're not going to go down that, because if a kid is struggling to breathe, like, we want our hands on them. If we get a listen, from a recording, we don't know if that's the right upper lung. We don't know where that is. So, but what I think is important for us is, I intended to be the hometown doc, the small town doc. That's what we are. So there's a relationship there. There's a very interpersonal relationship. So I will swing by and just see your kid on my way home. I will, it is important that we put our hands on you. So Blueberry Pediatrics is definitely fitting a role where, and they're, I believe they're thriving. I hope they're thriving, because they're providing something that, the status quo is not providing. So yeah, good job, Blueberry Pediatrics. I like to view them as a collaborator, because they're normalizing a market for us. But again, it's not like a specific doctor there. And so I think for us, the gadgets, the doohickeys, other things, that's not a worry for us. Something that I see coming up is something about like AI. Oh, AI is going to replace the doctor. No, they're not going to replace me. It's not. ChatGPT is not going to replace me, because there is something that robots just can't do, and that's be human. Absolutely. The human touch is just not there. I'm not worried about AI. Actually, if AI is there, like, I would, knowing me, I'd figure out a way to utilize it.
Well, you could bring Baymax, like an actual life-size Baymax, into your clinic, and I'm sure you'd get more patients just because they'd walk in the door to pick
that
up
would be awesome.
Baymax. Yeah. I would be there. Like, I would totally fly to do that.
Yeah, but there is something about an actual human and those human experiences. There's a reason why we slaved ourselves through residency. It's those experiences we're bringing.
And like, when you talk about humanism, I mean, look at what we're doing. Like, we're listening to your story, and that's what's making an impact in people who are listening. It's not like, oh, there's a picture of Dr. Gupta, he's so handsome, but like, no, he has a story behind like all the handsomeness. So, I think that,
thank you.
I think that is something that people need to hear, because it is a big thing that people are talking about right now. Like, oh, are we going to be replaced by the speed and the exactness that an AI might have compared to the human brain? And while
a traditional fee-for-service physician is being replaced as we speak, not from AI, but by the systems they work for already.
Absolutely. That one hits to my heart, because my husband just got replaced by a non-physician model at the clinic that he was working at. So amen to that statement. This is where, it is so heartbreaking for people to go to medical school, to go to residency, and to not be prepared with the fact that, like, no physician job is guaranteed. I mean, yes, like, we are business owners and we take a risk in DPC, but when you expect that your, golden handcuffs, employed role is guaranteed to last forever,
that's gone.
Yep.
Even if you're a partner somewhere, you think you got a cash cow, you got an income. No, your insurance reimbursements may drop, and you may get bought out. The other partners in your group might be like, hey, let's sell ourselves to Cigna. And that might happen. And actually, it does happen. And you will be replaced. That's where we're going. So I'm not even worried about robots or ChatGPT or AI. It's happening right now. You're being replaced, or you're being made redundant. Do more with less, right? It's all comes down to the lean operations. That is not a new concept. That is a concept that kind of makes capitalism work. Now, whether you morally agree with it in medicine, nobody gives a shit. So now for something like Rivertowns Peds, where I'm directly paid by the patients, we're thriving, we're growing. It's a slow growth, but it's fine. It's happening. It's growing. Now, right now, the economy is, looks like it's taking a downturn. I have some families who aren't able to pay me anymore, or that not able to pay the regular rates, their current rates. When I started this, there was a couple purposes. I wanted to make more money. I wanted to be able to provide the kind of care that I wanted to be able to provide the care that, like, I'm smart. Like, I want to make sure I provide the best kind of care I possibly can. I wanted to change my lifestyle. Well, one thing about being an entrepreneur is your lifestyle sucks. But also I wanted to send a message that this is going to be possible. And this is going to be this is going to be resistant to the whims of the economy. So we're starting to see a slight flattening of growth right now. But a slight flattening of growth is better than going backwards. So I'm not letting those patients go because they can't afford to pay me. I'm saying, look, I've been your pediatrician for years. Like, we got a relationship. I'm not going anywhere. And you're not going anywhere either. The amount of time, the relationship we have, look, I'll stop their payments. I'll stop the charges. And I know that when they're back on their feet, they'll pay me again. It's fine. I'm fortunate I'm in that situation now. 25% of our patients are on Medicaid or uninsured. I'm going to say we are going to be recession proof because, hey, when people lose their jobs, we're cheaper than Cobra. If they lose their Cobra and they're completely uninsured, we're cheaper than going anywhere else. So, your kids are going to be vaccinated. Your kids are going to get the care when you need it.
It's crazy. I think about coming up next month. There are, I think the number that I was told was like 116 kids who can't matriculate into seventh grade because they don't have their Tdap vaccine. And the public health department is needing someone to vaccinate and they don't have anyone. So I'm like, I'll do it. My husband will do it also because he is currently, joining my DPC, but we have the time to do these things. And so it was like, great, we have now people to vaccinate, but then, the uninsured or the people who have VFC can get the vaccines from public health, but then we can't get the vaccines for the other kids because they're insured. And so, they can't get in to see their provider, physician or non-physician provider before school starts. So, then how about we run their vaccines through their insurance at the local pharmacy and pick it up in a vaccine fridge and vaccinate these kids. There's 116 kids who can go to school. It's like, the idea that, again, it's like this health insurance is not healthcare. I mean, look at, if you're 25% of your kids have Medicaid, I can just imagine the number of clinics that are excited to take that reimbursement for each visit that they have. And, their accessibility, as I'm assuming like the Medi-Cal patients are, goes down because they have Medicaid or Medi-Cal. And so when it comes to that part of, being a disruptor and accessible care, that in some, families' minds is the number one thing. Like you're talking about, parents want a doctor that they can actually talk to when they need to. And that's what you're bringing. So as
those
those
Medicaid patients, they can't afford to go to a Medicaid doctor because they're working jobs. They need to be able to take their kid to a doctor that can see them, or have their babysitter take their kid to the doctor. We don't realize that insurance does not mean healthcare.
It's like, if there's one lesson that you've learned from this episode, like that is a huge one right there. When you guys, I mean, I don't think you're giving yourself all the credit that you guys deserve, because when you talk about recession proof and when you talk about growing slowly, like I want to really highlight that you guys are not going into the red, and you're growing with multiple doctors and now, multiple locations. So a couple of things, like I noticed on your logo, there's a trademark, which I think is flippin' awesome, because somebody asked me like, why is my DPC story trademarked? I'm like, because I worked my butt off to create this thing. Like, I'm proud of it. All
of our logos are trademarked.
Yeah.
You just can't take
it. So, can you speak to that? But then also, can you speak to how your Rivertowns Dobbs Ferry, and then we have now Rivertowns Staten Island?
So the branding, the logo, worked hard on it. I wanted a bat symbol. I wanted that logo to be visible, recognizable. So therefore those were trademarked. But there's two parts to that. It is balancing out the logo and the doctor. For me, they're not the same. And actually, if you look at your Google, like every month I get these Google kind of reports. So it's like 50-50. People are Googling Rivertowns Pediatrics, which I will say is a logo. And then they're Googling the individual doctors. We're not one and the same, but we're under the kind of the same symbol, the same logo. And I don't know, I just didn't want somebody taking my logo.
I totally get that. And like when I relate to that, my history, what I was exposed to was my dad created a logo for Eskrima. That's a martial art of the Philippines. And everybody has used this triangle and there's a knife and a stick. And it's like, he never trademarked it. And so now, everybody's using that idea, and my dad created it, but it's like, he had no protection. So, I think that it's like how you were exposed to compassion when you were in medical school and rotating. That was how I was, exposed to what happens when you don't protect what you have created. So I think it's super important for people to hear, especially as, the movement grows, consider getting your stuff trademarked, because, it's literally a way of helping your future self. I feel
it's on stickers, and I sometimes see that out on social media. Somebody took a picture of their kid and they, my logo is right there. It's kind of cool. And Staten Island has its own logo. Every borough we've been kind of brainstorming what logo for every borough of Manhattan, if we ever create another office in a different borough. For us in Westchester, our logo highlights the Tappan Zee Bridge. And so that is something the bridge is, the Rivertowns, the bridge is right here in our Rivertowns. It's something very it's recognizable for us. So for Staten Island, if anybody's ever taken the Staten Island ferry, you passed by the Statue of Liberty. So the logo contains the Statue of Liberty. For Staten Island. We're trying to figure out, we got ideas for Brooklyn, we got ideas for Manhattan, trying to figure out Bronx. Maybe we just won't open up an office in Bronx. They were like, well, can we do pinstripes? Like, no, the Yankees might get upset. We're still figuring out the Bronx. But you know what? Maybe I'm satisfied not even opening up an office down there. I don't know. But we are growing. We're growing slowly. We're growing well. There were times in the beginning where, especially in the first year, I asked my accountant, I was like, oh man, did I make a mistake? I'm not growing that much. I'm not making that any money. And he's like, give it time. I was like, should I take insurance? He's like, no, because my accountant has a lot of fee-for-service doctors in his practice. And he's provided me so much reassurance over the years. Like, look, they're failing. You have the right business model, just be patient. It will come. So I think a question I get asked a lot is how long did it take me for me to start paying myself? So first of all, my expenses have been paid starting after year one. Took about a year, for me to break even year one. I started paying myself after year two. Now I'm not paying myself again. Now maybe I'm taking more expenses out. I'm expensing a lot more, but I just hired a new pediatrician. I have other business ventures that I'm doing. So I'm pouring a lot more money back in. I am on payroll. So I am getting something, but I'm starting to look forward to the next pediatrician I'm going to hire. So I'm saving that up. So if I do pay whatever I'm paying myself, it's really with the mindset of I'm probably going to have to use this again to pay another pediatrician soon, probably in 2024, 2025. So I'm looking for the next one.
They might be listening to this podcast. So that's awesome. When you talk about hiring Dr. Gallagher recently, and then Dr. Brayev, and then also Dr. Solomon, I want to ask.
So Brayev and Solomon they're independent. So Gallagher is a true employee. Dr. Beriev is, he licensed the brand. And so with brand licensing is basically he pays me an annual fee. I set up his back office structure and then, whatever he's making. Dr. Solomon, she's a co-brand. So she was the first family practice DPC in Westchester. And then she was struggling financially. It just wasn't taken off. I was taken off, and I was like, I think 6 months in, we had a kind of like regular kind of meetings just to see how it was just us. Like I approached her initially to be like, hey, I'm starting up my own practice. I don't want to be viewed as a competitor, just as a collaborator. So we had regular kind of check-ins, and, after 6 months of me being, after I started, I said, hey, how are you doing? She's like, not good. I think I'm going to close. I was like, don't close. Maybe close this office, but come to my office. I have an extra room. I have a lot of the parents want what their kids are getting from me. So she's a co-brand. So I didn't hire her. She basically, and then once she joined, we both elevated it. It elevated both of the practices.
I don't know if it was at the Peds DPC Mastermind or if it was somewhere else, but somebody was talking about how, like, when you go get gas, you go off the freeway and it's like there's a Shell and a Chevron. Oh, is that you? Yeah, that was absolutely genius. Like, for people to really understand it's not competition but collaboration, and it increases awareness in the market. Like, that was it literally stuck out in my mind, because it's like, when a DPC opens, it means that there's a ton of people who are looking for that care that another DPC needs to open. Yeah. Not that like, oh, they're all going to jump ship and then go, because remember, they're buying into you as the doctor, and not, DPC.
They're not buying into DPC. They're buying into that doctor. And that's key. So if we're not competition, we're collaboration. Another pediatrician can open up across the street from me. I'm not going to care. I'm kind of at my own capacity anyways. Like, cool. I mean, I don't know why you didn't just join me, but okay, fine. If you want to do things the hard way, you can. But yeah, I think it's also important. A question I'm always asked is like, but with your model, how do we take care of everyone? I'm going to be blunt. I'm not taking care of everyone. I'm not. And do I care? Yeah, I care about the patients who are my patients. But, like us trying to take care of everyone, well, how's that going? Because we're not doing it. Like we're focused too much on the payment side, and we're not taking care of everyone. The kids are left behind. They really are. Just in your town alone, 119 kids need a Tdap, and half of them are insured. Well, how's that working out?
Well, yeah. And I mean, when we talk about equity, like, I think about how there's a family medicine doctor in the Santa Cruz area who has over 4,000 patients. And it's like, great, you have a doctor, but what kind of care is that? And how are you, how easy is it to get in to see that doctor? It's so interesting to hear people talk about their healthcare, and they don't see the value proposition sometimes of DPC, because they're so exasperated with the system as patients, so no matter what insurance they have, they could have double, Medicare. And
so I rarely ever talk about the finances. I rarely do, just because like the American public can't do math. We know that. We're famous for being poor at math. So I don't even talk about it. Because also I don't talk about it because that's just not my brand. My brand is not there to save you money on your insurance. You will. Like, we're priced well below the average family deductible of New York. You're going to save money with us. I just don't tell you that because I don't want to talk about it, because you're not going to get it. Most people don't get finances. So why even talk about it? What we should talk about is the care, and the care that, like, you know what? Your kid fell and needs stitches on a Sunday afternoon. Cool. I can meet you in the office in 15 minutes. Done. And, that's, that's it. Oh, and by the way, I don't say, by the way, I just saved you $1,200 on an ER visit. I never say that because I don't need to.
That's not what's going to be shared on Facebook. Like, oh no, Dr. Gupta just saw my kid in 15 minutes. Like, yeah. Don't you have that? Oh, I do. All of our kids do. Right.
Oh yeah.
Yeah.
Oh, this Sunday, This Sunday, I rented out the movie theater for Super Mario Brothers. So I'm going to take a selfie with 100 kids in my practice. It's going to be great. That's another thing. It's like, hey, yeah, it's fun. We're all going to hang out.
I love that. So
Yeah.
let me ask you this, because as you know, there might be, again, your future DPC pediatrician partner who's going to open the Brooklyn office and then help figure out the logo. When people hear about, this awesomeness of like, not only the patients getting access when they need it, but also that you're, like you talked about, like you're able to keep up your skills, you're able to do the things that you want to do as a physician and bring all of your nerdiness and all of your education and technical skills to being able to treat every single patient of yours. That is so attractive to medical students and residents. Like, hands down, when they hear what we're actually doing as doctors, they flip out. Like, they're like, and this has happened for years. And I love that the trend is growing, but like they migrate, like everybody wants to hear the one doctor talking about DPC. And as we're in this space of more and more people are getting educated about it, they're aware of it. And this movement continues to grow. What would you say to people who are thinking about DPC, who are also thinking about, could I, to pay off my loans, do an employed position? Because when it comes to New York and non-competes, that's a thing versus in California where it's not. So how would you advise people who are thinking about DPC to think about their contracts and choose them carefully and wisely as they're planning DPC in the future?
So universally, doesn't matter if you're in New York or California, do not sign a non-compete. Like, just don't. I mean, just physicians across the board, nationwide, have to stop signing non-competes. They're obsolete. You're obsolete. They've replaced you. They are easy to replace you. So why are you giving them the power to not let you work in your state again? Don't sign a non-compete. It's just ridiculous. And can you do an employed position and start up a practice at the same time? Is that your question? So for me, I needed, because I'm starting, this is a brand new market, right? I went 100% all in. I didn't sit by on my butt, like waiting for the phone to ring. No, I was out there just pounding the pavement. As I'm pounding pavement, I have Lauren, Dawn Creative Group, she's doing the social media marketing. I'm pounding the pavement, shaking hands, kissing babies. Basically, I was running for like the mayor. And that was it, just getting the visibility out there. If I were trying to do this on the side, as if I was doing my DPC as my moonlighting job, I don't think I would be where I am right now. I had to 100% commit to this. Now, is it doable? I think so, but I think really you have to be honest. Like, is your market ready for your practice? If your market is ready, if there's a couple of other practices in the area that are already doing it, then your market's ready. Then you could probably moonlight and build. But if you're creating a brand new industry, you kind of have to go all in on it. That's why, I don't know, you really do need to have that budget. You need to have a nest egg really set up if you're going to go this route. I think marketing DPC pediatrics is going to be much more of a challenge, because one of the first questions you might get is like, oh, but I already have insurance, and that's one of the things. It's like, well, you're not competing with their insurance. You're never competing with free, right? That's something you never compete with. You never compete with free. You compete on the product. You tell them what the product is all about. That's going to take time. And as a pediatrician, you have to tell these families what it is that you offer and what you're going to dedicate to their kids. So I think it may be a bit more challenging to do it if you have a full-time job to start your own practice. So totally. I don't know. I mean, is it done? I'm sure it's being done. I couldn't have done that.
What about your thoughts on how to incorporate DPC peds into employer health plans?
Yeah, I don't know. I tried and failed, because it just made zero sense, right? Child labor is not a thing in this country, so it just was not going to happen. Now, I do have a few employers who have paid for the memberships, only a few. But the thing is, look, a kid is going to be at least an 18-year commitment. People change jobs all the time, especially if you're in the tech industry, right? I think if you're trying to bank on employer paid memberships, you're going to have to deal with a lot of swings in your own financial stability because jobs change a lot. People keep moving on. So I don't think it's a market for peds. I don't think it's there. And I think it's too complex. In a state like New York, where everybody also has insurance, I just don't know where it's fitting. There's I don't know where that role is. So I wouldn't get too hung up on that. And that's my advice. Don't even bother with that part. Get hung up on how you're going to provide the best care possible for your kid.
I love that. So let me ask you in closing, do you have any other advice for people who are considering doing DPC in the pediatric space?
I think if you're going to go into the pediatric space, have patience, have a thick skin, and fully know yourself and why you're doing this. Know your why. What is your why? And know it, commit to it. And you really got to believe in yourself because, God, your family is not going to believe in you. My wife did, thankfully. But the rest of my family kind of questioned it. My neighbors definitely doubted it. My community definitely in the beginning doubted it. I mean, some people even called me evil for not taking insurance. But I think, it was the passion of pediatrics, of being a member of this community that really showed. And that's why we're thriving now. But it took a lot of effort,
And it's been well worth it. Look at the impact that you're making. So thank you so much, Dr. Gupta, for joining us today.
Thank you. Thank you for having me. I'm honored to be here. And I'm glad I finally get to sit and chat with you.
Next week, look forward to hearing from Dr. Lola Ashaye of In Touch Primary Care in Sugar Land, Texas. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.